Um, Hello, good evening, uh, and welcome to Advanced Cell Group webinar series. I'm Dr. Lippi, a stem cell expert and clinical scientist, and working as a vice president in Advanced Cell Group. So, topic of today's webinar is stem cell therapeutic potential in poor ovarian reserve and premature ovarian insufficiency. As you all know, the stem cell is the native healers that comprise of all bodies, tissues, and organs, and have power to transform into any cell type and then when contact and divide indefinitely and regenerate and heal our entire body. So as a result, it can be used for treating infertility in women. There is no known treatment available for ovarian reserve enhancement and in vitro fertilization is the most common treatment for the women with a decreased ovarian reserve. So stem cell technologies have potential to treat diminished ovarian reserve and premature ovarian insufficiency. So this stem cell could massively increase the overall female fertility level by facilitating ovaries regeneration. Can also help the tissue in the uterus and help the other organ to produce normal cells to give proper manner, and thus women can get rid of their infertile state and pave the path of the motherhood. So taking not much time, today I'm inviting Dr. Rita Bakshi, is a renowned gynecologist who is the chairperson and Resea IVF's fertility center in Delhi, and also the founder of IDIVA group of hospital. Dr. Bakshi ma'am was awarded with the WHO Fellowship for AIDS in gynecology, and she's a senior consultant in fertility and specialist and endoscopy surgeon. And she also chaired the faculty at the Institute of Reproduction Fertility Center at Delhi. She has various research projects funded by ICMA DBT, and she also member many society and has been the part of organizing committee for various workshops and conferences. So I request Dr. Bakshi ma'am to start the webinar with a valuable insight on stem cell and female infertility. And we'll take the questions at the end of this talk, or you can also drop the queries via the chat box. So please, ma'am, can start now.
Thank you so much, Dr. Lippi, for your kind introduction. And I'm very happy to be talking on a subject which is going to become very, very important in the coming days to come. With the ART and surrogacy law in place now, no more are the egg donors going to be so easy, and neither surrogacy is going to be allowed. So the field of regenerative gynecology is really going to come of age. Let's talk of stem cells and how we can really make use of this technology. So is my screen visible? Is my screen visible, Lippi?
Yes, yes, ma'am.
All right.
Yes,
all
yes,
right.
ma'am.
All right. So our topic is the therapeutic potential of stem cell in premature ovarian insufficiency, or wherever you think that you can do with a few more oocytes than what are present. So if somebody is interested in having their own genetic offspring, then this is the field that they should be looking up to. So let's start with the first question that what are stem cells? Now, stem cells have two key properties. They are the foundation cells for every single organ and tissue in our body, and the highly specialized cells that make up, they come from a pool of stem cells which are formed shortly after fertilization. Throughout our lives, we continue to rely on these stem cells, which whenever injury is there, it is these cells, whether it is skin, hair, blood, gut, wherever, then these are the ones which will replace our injured tissues. So stem cells have the two key properties. One, they have self-renewal, and second is plasticity. So we understand that they can multiply and they can renew themselves. The progenitor cells are the cells which are encompassed from the immediate progeny of stem cells to differentiation cells committed to one lineage. So, stem cells are the ones which, which can convert into anything. The progenitor are the ones which will differentiate to one lineage. They are developmentally restricted and they become progressively more restricted as we go ahead. So the late ones eventually, will either be endoderm or ectoderm or mesoderm. And the mature cells, that is, from these progenitor finally will become the mature cells. So in every single tissue, you have these stem cells, which can self-renew and which can develop into progenitor cells, and progenitor cells can become mature cells. So depending, the stem cells are divided according to their origin. They can come from the embryo, they can come from the fetus, from the infant, or from the adult. From the embryo are the embryonic stem cells. When we will go ahead and show you how the best cells are there in the embryo, and if we can use the embryonic germ, of course it's not allowed, but embryonic germ stem cells can develop into any single line. Then, of course, the umbilical cord and the jelly, the water jelly which lines the cord, are the two other sources from where we can get the stem cells, which can multiply into any kind of cell. Now, according to the differentiation, they can be totipotent, pluripotent, multipotent, or unipotent, or oligopotent. And adult stem cells can be according to the tissue: pancreas, liver, epidermis, gastro, neuro, cardiac, hematopoietic, mesenchymal, any kind of tissue. So the main source are either adult umbilical cord on the water jelly or the embryos. Now, just to show that one oocyte is a single cell, when fertilized with a single cell sperm, develops, multiplies into 2 cell, 4 cell, 8 cell, and this 8 cell can develop into a multi-level body plan. So if we can take out the cell, it is a full organism itself. These are totipotent cells. Then, of course, day 4, day 5, we have a blastocyst, and then when we culture them even further, they develop into a pluripotent cell. So this is just to say, the earlier they are in fertilization, it is at that time, if you take out a cell, it's a totipotent cell. It can develop into any single thing. So just to differentiate between toti, pluri, and multipotent, totipotent cells are the one which are before 8 cells, from the zygote to the morula, they can, these cells are 4 cell embryo, and they can differentiate into extra embryonic, and they are easy to isolate, easy to grow, unlimited self-renewal. The con part is their high risk of tissue rejection. Ethical issues are there. They can develop into teratomas. So totipotent stems are not allowed except for research purposes. The second is the pluripotent cell, which is, from the blastocyst, or the umbilical cord, or the reprogrammed induced pluripotent stem cells. They can also differentiate into the 3 germ layers. Again, they are easy, but an unlimited self-renewal, but again, high risk of tissue rejection, and ethical issues are there, and teratoma formation. The third is the multipotent stem cells, which are developed from the organs. They can differentiate into any specialized, hematopoietic, epidermal, skin, hair, bone, cartilage, wherever there is injury, you can use these multipotent stem cells. They are hard to isolate, and they have limited differentiation. So totipotent from the early zygote, then pluripotent from the blastocyst, and finally the multipotent stem cells, which we can develop from blood or skin or any other tissues, which all have got. So just to look at the history, how did it start? It was 1963 when we discovered that there are renewing cells in the bone marrow. In 1968, between the two siblings, transplantation was done and it survived. In 1981, embryonic stem cells isolated from the mouse blastogen, and this won a Nobel Prize. Finally, 1992, adult stem cells were identified in the human brain, and it was in 2001 that mouse embryonic stem cells created using nuclear transfer technique. In 2006, it was induced. So we'll tell you, induced pluripotent stem cell. This again won a Nobel Prize. You know, you can induce the stem cells to develop, and this is where the whole treatment is now focusing on. In 2010, not at all long back, medical treatment using human embryonic stem cells for spinal injury. And this is where, you know, where nothing really works. Started treating the spinal injury patients. And in 2014, the embryonic stem cells from the adult insulin producing beta cells generated from skin cells. So, you know, we'll talk how skin cells can develop into an egg, a sperm, a pancreatic cell, whatever you want. And this is as early as 2014. So how do they work? This is just to say the stem cells have a communication system very similar to an immune system. They act on signals from the immune system. For example, whenever there's infection and inflammation, tissue breakdown, then they trigger the migration to the affected site, and they start differentiating and start replicating and heal the area wherever they are. So what happens when we age? When you age, they also age. For wound heal faster when one is younger. Of course, it is difficult. So we know that the ability to communicate with the body and environment becomes less efficient as we age. So we already talked about toti and pluripotent cells from the embryo, which are easy to isolate, unlimited self-renewal. But the risk of tissue rejection is high. Ethical issues are there. Embryos are not to be used for this, and possible tumor formation. So something which can multiply like anything can also give rise to tumor or teratoma formation. So this is the con part of it. Multipotent adult stem cells, of course, they are less likely rejection, less ethical issues, safer, harder to isolate, and limited differentiation. So what are the adult stem cells that we know of? We know that bone marrow, we can aspirate the bone marrow, concentrate within. So what is autologous and what is allogenic? Autologous means your own body, from the bone marrow, from the dental pulp, from the fat, liposuction. If you do the liposuction, it's got a lot of stem cells which can be used to treated, and then they can be treated to treat disorders, which we'll be talking. And of course, cryogenic stored umbilical cord blood from a donor, which is an allogenic. So this is not from your own body, but from same species. So it is allogenic. You can deliver the stem cell either intravenously or locally, wherever the injury is there. So adult stem cells, we are aware that a lot of orthopedics are using in bone, cartilage, adipocytes. We can use the fat for healing cartilage, muscle, nerve, heart, anything that you can think of. So coming to the hematopoietic stem cells, we know that bone marrow, even the peripheral blood, progenitor cells, the umbilical cord blood, these are the stem cells which are in the blood itself, and the property of self-renewal keeps the marrow cellularity or the stem cell pool constant in a steady state in healthy individuals. So the importance of the umbilical cord, this is the cord which connects the baby with the mother, supplying the nutrient-rich food. But this also has the mesenchymal stem cells, which are non-hematopoietic. They are multipotent with the capacity to differentiate into mesodermal lineages, such as osteocytes, adipocytes, chondrocytes, as well as neurons and endodermal liver and hepatocytes and other pancreas cells. So the cord tissue, which is an allogenic stem cell, can be used to heal any of these. So mesenchymal stem cells are multipotent, that are primarily isolated from the bone marrow, but the adipose tissue, as we talked, are also all you can directly plate them because it has the adherent properties, and you can use the cell surface markers. Both methodologies have their limitation, but homogeneity of the purified population obtained through adherence to the culture plastic is not high. So only 10 to 20% cells are capable of multipotent differentiation. Culture of the mesenchymal, the isolated cells. So around 40 population doubling is a result of, because of telomere shortening, you can't do too many doubling of these cells. You can multiply these mesenchymals around 40 times. Culture cells have demonstrated genetic instability after 250 population doublings when using expanded cell culture. So around that is the kind of limitation these adult mesenchymal stem cells have. But highlighting the need to scale up this, because you can see that there's going to be abundant supply of these cells which can be used into anything, and you can obtain the mesenchymal from the placenta, from the dermis, endometrium, dental pulp, Wharton's jelly, adipose tissue, any of them. Now, you know that cord blood, cord tissue, as I said, is a easier, simple, safe, painless. Immediately you can, they're available, and you don't require matching. Now, that is the difference between bone marrow. It is difficult to find a perfect match, and you require 6x6 matching. While here, really speaking, cord tissue does not require matching at all, and even cord blood 3x6 or 4x6 matching is enough. The stem cell concentration, of course, cord blood has highest hematopoietic, while cord tissue has mesenchymal stem cells, while the bone marrow has hematopoietic stem cells and mesenchymal both stem cells. So what about the induced pluripotent stem cells? Now, this is a lab technique. You reprogram by putting the transcription factors, transforming the adult stem cells into pluripotent cells for research purpose. Again, this is being done for research purpose. If you have an adult fibroblast cell, and if you can see by using SOX2 and OCT34 and all this, you can reprogram the cells. So this is induced pluripotency into a cell. Now you can reprogram and make it into blood or pancreas, nerve, adipocyte, cardiac, wherever you want to use. Now this sounds so wonderful. So where do we use? We know that autologous, that means from your own body, fat and bone marrow derived stem cells, and which you are using for the eyes disorders, especially retinal degeneration and other degenerative disorders, where you want, there's nothing else which will work except stem cell. Organ specific disorders, neurological disorders, while allogenic, that means from the cord blood derived mesenchymal stem cells, can be used in skin, then in infertility, female and male, to develop more of a female and male wherever we have seen. And I will give you my experience also, a little bit that I have in aging disorders. It now in cosmetic line, stem cells and allogenic therapies are finding great use in aesthetics and in sport injury. So autologous stem cell, you can see how it is coming. You can take out from in the right side figure, you can see so the left side is autologous stem cell, and on the right side you can see an allogenic stem cell transplantation. So in your own autologous from the bone marrow collection of stem cells, they are mobilized by giving a GCSF injection. The stem cells are mobilized, and then you can take out from you can take a blood sample, or you can take out from the bone marrow from the iliac crest itself. You can reprogram, process and condition and treat, and then reinfuse back into the patient to heal the area that is required. In an allogenic, we know that it is a donor which we can again collect the donor cells, process, condition, and then infuse back into the patient. Now, this is a beautiful system developed by Advanced Cells for developing the PRP versus a manual method. You can always do a manual method also, in which you are taking the blood and mixing it, and then collecting the buffy coat. But see how beautifully it is done in a system like this, where this tiny neck is the area where, you know, all that you have to do is take out. So they give you a long needle which goes directly into this area, and you can just take this out and use it. So this is the system that we are also using in our center to develop platelet rich plasma. So stem cells are one, but if you can, the platelets and the platelet rich plasma has got a lot of growth factors, which we are also using for ovarian and regeneration. Now you can see the PRP we just showed you. These are the platelet rich plasma is collected after centrifugation, and if you can see the area, these are in a test tube, the RBC collect at the bottom, you have the platelet rich plasma in between, and then you have the platelet poor plasma. By taking out the platelet rich plasma, activating it with calcium ion, and then you treat it, and whether you inject it into the ovary or you inject it into the uterus, it's very rich in these factors, which helps in follicular genesis as well as angiogenesis. And you can inject it either through a laparoscope or through the vagina. Within ultrasound, we can inject it into the ovary. So this is where the ovarian rejuvenation, and if you see, the hormonal profile improves, her AMH changes, and the antral follicle count also increases. So this is the thickening of the endometrium. A lot of studies have gone by where you can see that so many authors are now coming up of using for thin endometrium, whether they can use PRP, which, as I said, what you want is thickness. So you want the cells to multiply, you want newer blood vessels, because this is what will matter. And this is how anti-fibrotic, anti-apoptotic, angiogenic, and increasing all the numbers. So this is how it works. Now, these are the studies in which bone marrow stem cell treatment has been used. You can actually go through the studies. I can put them all for everybody to see. Still ongoing studies are there. How many POR, poor ovarian reserve patients have, and what are the changes that have occurred, whether pregnancies happened or not, is all something. So what it was seen in some of them, 80%, there was improvement in 2 weeks after treatment, 33% increased pregnancy rate, and they reported 5 pregnancy and 3 live births. So I'm not saying it's like a magic pill, but yes, when nothing else works, then this probably is something. So you can see people have used PRP, they've used bone marrow stem cells, activated PRP, and so many studies which have been done, some into the Asherman syndrome. They've used human PRP, down-regulates the fibrosis and restores the uterine function of the impaired uterus, and improves the outcome with full-term delivery, also noted. These are something which are totally hopeless. Asherman is something that really you have no idea what else to do. So when they have used with bone marrow stem cells, they've combined also, and they have seen, so you can really look at, pro-inflammatory, they have down-regulated the pro-inflammatory genes, and promoted endometrial growth in all these. These are the other studies which you can see when they have been added to estrogen, and then they have also combined. They've taken menstrual reconstruction, again looked at whether the menses return in autologous stem cell in Asherman syndrome. Then of course they've used bone marrow in thin endometrium, and so you can see that a lot of the people have been looking at this extremely closely, because this is the only hope left. Now, there is something, newer coming up like exosomes, which are, so we know stem cell, we know autologous, we know allogenic, but there are something called exosomes, which are tiny, very tiny nanovesicles, which are there in the body fluid. And whenever cells are multiplying, these tiny vesicles are coming out. And due to their sizes, they were considered trash. However, when advancement occurred and people looked at them, they became part of a meticulous intracellular communication system, and they are known they have a huge role in cellular communication. So autocrine, that means between similar type of cells, and paracrine, between different cell types, as well as distant or endocrine organs. So they are improving the communication. As IVF experts, we really understand a good embryo put inside an endometrium, which is looking good, but the signals or the signalosomes or the communication between the two, which is required, as a part of the immune system, is what is lacking. So these exosomes, when introduced, they can enhance the communication via all the channels which work. And they compared to adult stem cells, exosomes contain 300% more growth factors, which are essential for cellular growth, development, regeneration. They can be given via IV infusion, or they can also be given directly into the local area. So if you can see, the cells, how they are when multiplying by pinocytosis, these are the tiny vesicles which are released. And you can see that the cascade, the signaling cascade that is activated whenever they are used. So you can see the nanoscale, they are one of the paracrine mediators. They are very small, 30 to 150 nanometer, containing protein, RNA, lipids, and secreted by all cell types in culture and found in most body fluids. So mesenchymal stem cell derived exosomes are considered as a newer, a modern approach in translational medicine. So you can see that exosomes have been used in infertility treatment, in POI, in patients who've had chemotherapy and radiotherapy and have destroyed their potential of genetic offspring. And in these cases, as well as in premature ovarian insufficiency patients, they have used whether mice model or rat models, they have used these intraovarian injections and have seen decreased apoptosis and targeted much upregulation of the enzymes that are required. Now, when we are talking of this, we are also talking of in vitro activation. Now, of course, inside the body, we have seen what we can inject, but outside, the POI patients, they carry residual dormant follicles in the ovaries, which can be used. So there is what we can do is we can take.
Sorry, ma'am, we are sorry for interruption, ma'am.
Yeah.
We have 4 minutes left. So
okay, all right. So I think we've covered most of it. I'll just say, so drug-free IVA. Mitochondria is a powerhouse. We can always activate them, and they can become, activated. Now, this is all stem cell therapy that we have been using, and I think I've already explained all this. The homing, differentiate, I've already explained the source of embryonic, the mesenchymal, the spermatogonial, and the induced stem cells that are there. So there's an ovarian niche or the microenvironment, which is causing aging, and you can always find, so I will just show you, I think, the mechanism, how we are doing this. We can, so this is the transvaginals, you see, from the iliac crest, the bone marrow is taken out, and then it is prepared, that you can see in any of the ways that you do it. And then this is the buffy coat, which we can take it out, which is a WBC and platelets. And this is how, through a laparoscope, we can inject into the cortex. Similarly, intrauterine injection, we can do that in the thin endometrium. And well, the law and regulation, there are a lot of things we can talk of the laws later. The embryonic we know are harvested. So any question that are there, please keep putting, and Lippy, you can also take we should have appropriate consent, waivers, and expectations should be normal, genuine, and you cannot really make something extraordinary and give them something that we say, but then this is here to stay. Ovarian rejuvenation with PRP, with stem cells, with exosomes, we have so much to offer. So whether it is Asherman or atrophy or bone, wherever you require, these are the substances which we can use, and this is where stem cells come into use. So Lippy, I think I still have 2 more minutes left, so you can take over from here. And if there are any questions, then we'll be happy to answer.
Thank you, ma'am. And we also want to say about because we have done some of the pilot study on POI and endometrial thickness, and we got the very good results, and we're compiling our data, and we are about to publish that paper. We definitely announce you for that publication soon in a month time, and we are very hopeful for treatment with infertility with the stem cells and PRP. So so any medical doctor here, they can use for further if they want, and get guidance from us if they need. We are happy to help you in that. Thank you.
In fact, I would also say, Lippy, that in an azoospermic patient, we had done the bone marrow stem cell autologous insertion into the testes, and we got a few sperms. So this is something that I have really experienced on my own. We have done the intra-ovarian as well as in endometrial. We have been doing this through a hysteroscope and through an ultrasound guided. We've regenerated both the uterine lining as well as the antral follicle count. Thank you so much, Lippy, for giving me this chance to speak on this topic.
Thank you, most welcome. Any question, please? Or you can write to us, info@advancedcell.com for any queries, or you may ask here as well.
Thank you, Lippy.
Thank you, ma'am. Thank you.